Good evening and welcome to today's discussion on driving and seniors, part of the Caregiver educational series sponsored by Lehigh Valley Aging in Place. When we think about driving, it's a task we often take for granted unless circumstances change, which may affect our abilities to perform the task. If we go a step further and were to define the term driving, it can be described as a skill that uses visual function and acuity, processing speed, attention and focus, social awareness, motor control, cognitive processing, and mental flexibility, amongst several other functions. There's a well-defined entry point for starting to drive, such as getting a learner's permit at age 16 and eventually a driver's license at age 17. But one has to pause when it comes to an actual exit point for driving cessation, because there are no set guidelines that tells you when you should stop driving, nor is there a set age to discontinue driving. Often I'm asked by my patients whether driving is a right or a privilege. And regardless of the answer, we know it's very important for a person's self-esteem, independence, and freedom to be able to drive. When we look at the data, by the year 2030, 74 million Americans will exceed age 65. And according to statistics, more than 75% of those people will carry a driver's license. The question is, what percentage of these seniors will be fit to drive? As we get older, many of our body system functions and physiology change, which is part of the normal aging process. And these changes can affect and have an impact on our ability to drive. For instance, our vision changes as we age with respect to contrast sensitivity and glare resistance. We may develop decreased focus and reaction time. We may also develop decreased motor coordination and flexibility, as well as decreased multitasking. The data has also shown that increased age is associated with more driving errors, poor performance on road tests, and increased crash risks. Physical conditions such as seizures, movement disorders, stroke, ophthalmic conditions as macular degeneration, or mobility conditions as severe arthritis, to name a few, can prevent persons from being able to drive safely. Also, medications can affect driving, especially those medications that have side effects of drowsiness, impaired coordination, or brain fog. And these are some side effects we often see with psychotropic medications or mood medications and pain medications. Within the United States, there is what we call mandatory reporting of patients with specific levels of cognitive deficits who continue to drive. So, as physicians, we are obligated legally to inform the Motor Vehicle Commission about such patients. The reporting is currently enforced in states as New Jersey, Delaware, Nevada, Oregon, California, and Pennsylvania. Many other states encourage reporting but do not mandate it. In Pennsylvania, healthcare professionals are mandated to report to the Pennsylvania Department of Transportation, or PennDOT, any individual who has medical conditions that can impair their ability to drive safely. Of approximately 35,000 reports submitted each year to PennDOT, about 10,000 individuals have medical impairments significant enough to merit recall of their driving privilege. An additional 21% of reports result in restrictions placed on the individual's driving privilege, and half of these persons involve drivers over the age of 65, according to information released by PennDOT. As a geriatrician, many of my patients I see are consultations for cognitive and memory impairment. Very commonly, a diagnosis of Alzheimer's disease or other types of dementia is made, and driving is one of the many components of the disease process that needs to be addressed if the patient is still driving. This is because, as I mentioned earlier, driving is a complex skill that requires integration of several functions. With diseases as cognitive impairment or dementia, patients may have changes in their brain structurally, for example, in their medial temporal lobe of the brain, which would not facilitate them to learn new things, and it affects their short-term memory. Or the patient may have deficits in other domains or brain functions, such as attention or multitasking. This then raises the question of how safe is it for a person who has such cognitive deficits to continue driving? To help in deciding a person's ability to continue driving, I often rely on family members or caretakers for this information. Per the American Geriatric Society guidelines, we typically will ask caregivers a list of questions when we do our comprehensive neurocognitive assessment. So, for instance, we will inquire, does your loved one have memory issues or forgetfulness? Are they making good judgment calls when they're driving, such as taking the right exit or knowing when to go at a four-way stop sign? Is your loved one getting more traffic tickets or warnings? Are they getting lost going familiar places? Are they telling you, oh, I've had a really close call a couple of days ago while I was driving? Do they have dents or scratches on their vehicle? Are they easily distracted? Are they failing to obey traffic signs or signals? Are they cutting off drivers or straddling lanes or making wide turns? Are they reacting slow to emergencies? Are they falling asleep behind the wheel or appearing inattentive? Are they becoming easily angered or agitated? Are they using poor judgment, such as not yielding right of way? Are they forgetting to use their side mirrors or turn signals or check their blind spots? Or are they having trouble judging distances? This list of questions, if the answers are yes to some of these questions, this is a red flag or a warning, because it may be an indicator that your loved one should actually stop driving. So if there are concerns about your dear one's driving, the first step is to have the individual's primary care physician do a general evaluation and examination. You may also want to see an ophthalmologist and have a vision test performed. Often, our geriatric team will get referrals for medication review or polypharmacy, but more typically, we get referrals for neurocognitive assessments. As part of the neurocognitive evaluation, we use cognitive screening tools, which will assess particular brain domains or functions, such as visual spatial or executive function, attention, memory, and delayed recall, amongst other domains. If there are deficits in these brain functions, we often will refer the patient for a driving evaluation, simply because these brain functions are an integral part of our overall cognitive function when we complete a task as complex as driving. Our referral for a driving assessment is made by referring to St. Luke's Occupational Therapy Department for a Fit to Drive test. This test assesses a patient's reaction time, initialization and reaction, how they track and process visual events, their ability to encode, retrieve, and respond to stimuli, judgment of spatial relations, their decisions under time pressure, their guided movement control, their ability to respond quickly to complex information, fine motor control, and impulse control. The end result is a percentage that's reflective of the probability that the patient will fail an on-the-road test or create a hazardous situation on an on-the-road test. This particular evaluation done at St. Luke's Occupational Therapy is fully covered by insurance. Now, there are other organizations such as Good Shepherd who provide a combination behind the wheel driving test as well as cognitive testing. And there are other independent organizations that may offer a more personalized service by going to the patient's home to conduct a driving evaluation. Depending on the results of the driving evaluation or the results of our neurocognitive assessment, a patient's license may need to be suspended. It's a very difficult task to suspend a driver's license. Not only is it heartbreaking, but it creates a very angry atmosphere and often can change the relationship between the patient and the physician, or even the patient and their family member or caretaker. Often we have patients who will blame family members for ruining their lives by bringing them to our office for an assessment. But overall, more frequently, we as the physicians bear the brunt of angst and retaliation. I typically will bring my patients back into the office or schedule a telemedicine appointment to review the results of their driving evaluation so that we can avoid family members from facing anger by themselves. Also, it allows the opportunity to explain to the patient where they scored poorly on their driving evaluation in an effort to make them understand why their driving is a safety concern. When revoking a person's license, one has to prepare for the angry outbursts because we are taking a part of the patient's independence and freedom away. We've had patients threaten us, state they will sue us, they will call the police, They often curse, they will insult, they'll hurl verbal explicits towards us. But as the medical provider, one has to be understanding and empathetic, particularly towards patients with cognitive deficits. Sometimes our geriatric evaluation can identify conditions that can be treated, improving a patient's ability to drive, but these are very few and far. It's important to realize that suspending a driver's license does not necessarily prevent a person from driving, as often persons will ignore, either intentionally or unintentionally, the suspension, especially if they have memory loss and may continue to drive. In other cases, the vehicle may still be located at the patient's home, in the driveway or garage, with easy access to the vehicle. In such cases, we recommend to family members that they keep the keys so that it's away from the patient. We sometimes recommend parking the vehicle down the street, away from the house, or in some cases, ask family members to remove the battery, because some patients may not realize their own deficits. We have had several patients with dementia whose families relate stories at their initial geriatric intake about their loved ones ending up traveling out of state after getting lost, going to, for instance, the local grocery store. And 8 hours later, they're found by state troopers after they've run out of gas and lost. When we meet such patients and hear these stories, it's a very scary experience for families and providers, because this raises the question, should more attention have been paid to the person's driving habits in the past, or were there red flags which may have been occurring but were being ignored? When considering whether to confront a loved one about the need to stop driving, remember that as a caretaker, as a family member, as a friend, you're doing this because you care about them. They're at risk, and other people on the road are at risk. You want to make sure that neither they or anyone else could be harmed or even killed because they're behind the wheel. Some of our recommendations to patients as they are aging is to plan for early retirement before it becomes an issue. We suggest helping this process by transitioning the driving to another person. Reduce the need to drive for certain errands, as groceries, with online shopping. Research refresher courses which are available by the AARP or AAA, and be aware of transportation options locally. Ultimately, it is important to consider the whole picture, which allows balancing of autonomy with safety. Our duty is to protect the patient's passengers, and the public as a whole. Thank you, and have a good evening.